and welcome. Good evening, everyone, and welcome to the Vision Care Association webinar series in collaboration with the Eastern Mediterranean Council of Optometry. Tonight's session is titled Integrated Neuro-Optometry into Everyday Clinical Practice, and it promises to offer valuable insights on enhancing patient care and outcomes through neuro-optometry. I'm Hassan, and I will be the moderator for this session. It's my pleasure to introduce our distinguished speaker, Mr. Charbel Faraj. Mr. Faraj is a highly experienced clinical optometrist specializing in pediatric and neuro-optometry. He holds a degree in optics and optometry from Beirut, a master's in clinical optometry and vision therapy from Universidad, Isabel in Spain, and a certification in healthcare operations from Rutgers University in the USA. He's currently pursuing a doctorate in business administration in Rome, Italy. With extensive expertise in clinical management, research, and advanced optometric care, Mr. Faraj has played an instrumental role in establishing optometry service in hospital and medical centers across Lebanon, the UAE, and Qatar. He is also an active member of the World Council of Optometry, the American Optometric Association, and the British Contact Lens Association. His research on the effects of digital screens on dry eyes, blinking rates, and tear quality has provided valuable insights into modern optometric challenges. Before we begin, please note that we kindly request you to keep your microphones and cameras off to avoid any interruptions. If you have any questions during the session, please type them in the chat box and we will address them during the Q&A session at the end. And last, the recording of this webinar will also be available for replay on the Vision Care YouTube channel. Now, without further delay, Mr. Charbel, the floor is yours.
Thank you so much, Hassan, for the introduction. Thank you, VCA, for this opportunity. Today, we're going to be discussing neuro-optometry and how to integrate it into everyday clinical practice. So we need to understand the importance of neuro-optometry and how it can provide insights on our clinical cases we see on a daily basis. So many patients have underlying neurological conditions affecting vision, and optometrists play a crucial role in early detection, management, and referral. So let's see what's a neuro-optometry. Neuro-optometry is a subspecialty of optometry that focuses on how neurological conditions impact vision. And it involves visual processing and perception, oculomotor function, vestibular ocular integration, and binocular vision disorders related to brain dysfunction. So over 50% of the brain is dedicated to vision, and damage to different parts of the brain could result in specific visual dysfunctions. Those are the most common neurological conditions affecting the vision. So, for example, a stroke could lead to a hemianopia. A traumatic brain injury could lead to a diplopia, multiple sclerosis, very popular, causing optic neuritis. A Parkinson's disease that could cause a saccadic dysfunction, migraine and vestibular disorders, which cause light sensitivity, and cranial nerve palsy, especially the third, fourth, and sixth, which cause diplopia, ptosis, and impaired eye movements. What are the key assessments every optometrist should perform? This is a very small list. Definitely, there are more tests to do, but I'm going to be discussing those 9 tests today. We're going to first start with the visual acuity and refraction. Basic, every optometrist does it, and it identifies subtle visual changes due to neurological conditions. We use a Snellen or Logmar chart to measure visual acuity. Then we do the pinhole test to differentiate between refractive error and potential neurological impairment. And then definitely the subjective and objective refraction to detect subtle refractive changes often affected in cases like optic neuritis. Second key assessment in neuro-optometry is the accommodation testing, and it evaluates the ability to focus between near and distant objects. Tests used in accommodation are mainly 3. First, we start by the near point of convergence, or the NPC test, which assesses the ability to maintain binocular vision at near. So we use a fixation target, we bring it slowly towards the nose, until the patient reports diplopia or when we see a break in fixation. The normal range for NPC test is usually equal or less than 5 centimeters for the break point and 7 centimeters for the recovery point. Second test in accommodation is the accommodative facility testing using lens flippers. And this test determines how quickly a patient can adjust focus. We ask the patient to read a near chart, and then using flippers, we flip between +2 lens and -2 lens, and we assess the speed of focus. The last test in accommodation is the monocular estimate method retinoscopy. And this test evaluates the accommodative response, and the normal range usually is between +0.25 to +0.5 diopters. Moving to the next assessment in neuro-optometry, which is a really important test, is the visual field testing. It identifies visual defects, and we usually use it in confrontation or in automation. A confrontation visual field is a quick, free in-office screening, and we just ask the patient to cover one eye, and we report when they see a moving target in peripheral vision. We'll just watch a quick video on confrontation visual testing.
To screen for gross visual field defects, ask the patient to identify fingers displayed first before one eye, then before the other.
1, 2, 1, 1, 2, 1, 1, 2, 1, 3, 1, 3, 1, 2, 3, 4.
Suppose the patient cannot see any fingers displayed in a hemifield. Here's what you should do. How many?
1, 2, 2, 1.
Tell me when you first see my finger by saying the word now.
Now. Now.
There is
So that was an example of how we usually do the confrontation visual field test. So moving to the automated visual field test, usually using Humphrey or Octopus machines, it maps out detailed visual field defects. And we use those machines to present a visual stimuli at a different location, and while the patient presses a button upon detection. The results of automated perimetry usually is a document. And in this document, we have a lot of data, we have a lot of maps that we have to analyze to see the results of the visual field. So the first thing we need to see in the visual field in the top area of the document is actually the test type or the area tested. And this is usually chosen by the practitioner or by the doctor to test a specific area of the visual field. Usually we choose 30-2 for neurological cases, we choose 24-2 for glaucoma cases, and we choose 10-2, which is the smaller one, to test the macular area, such in advanced glaucoma or such in macular disease. The second data to look into is the strategy. So the strategy could be standard or fast, depending on the case we have. One of the most important things we don't have to miss is to use the lens, especially in cases of significant refractive error or in case of presbyopia. So the patient could see properly during the visual field test. Moving to the next set of data are the reliability indices, and this includes fixation losses, false negatives, and false positives. And those indices should have a value of less than approximately 15% to consider the test reliable. Otherwise, the test should be repeated. And this is really varying between patients, especially if the patient is doing the visual field test for the first time, and that requires a repetition after a few days or few weeks, or maybe an old man who couldn't really pay attention during the visual field test. We move to the maps, and we have the total deviation map and the pattern map. And the total deviation map gives us the real deviation of each point comparing to a normal database. And then the pattern deviation, which is the most important map, because the software of the machine actually removes the generalized decrease in sensitivity from the total deviation, and it keeps only focal a loss of sensitivity, which is caused usually, for example, by glaucoma. On the right side of the document, we always have those for data, the GHT, which is the glaucoma hemifield test, which compares the superior hemifield to the inferior hemifield. And if there's a certain amount of difference, it means there could be a diagnosis of glaucoma. The MD, which is the mean deviation, and it should be, if it is less than -2, actually it indicates a glaucoma. PST, or pattern standard deviation, and this is important in follow-up visual fields to monitor glaucoma progression. This is one of my favorite illustration in visual field defects, and I have it all over my clinic. And it is really important to understand where the lesion in the visual pathway is compared to the visual field defect we get. So you can notice if we have a pre-chiasmatic lesion at the level of the optic nerve, we always get a monocular defect. If we get a chiasmatic lesion, we have always a bitemporal loss. And if the lesion is post-chiasmatic, we have a homonymous defect that could be a homonymous hemianopia or a homonymous quadrantanopia. Fourth test in neuro-optometry is actually the contrast sensitivity testing. It's an underrated test, we can say, and it's usually done with two tests, either the Pelliropson or the Mars letter. They are really similar, but the Mars letter test has a smaller testing format. We put the Pelliropson contrast sensitivity test at a distance of 1 meter, and we let the patient start reading from top to bottom until they reach the very small faded letters. And we note the value we got in log CS. And usually the normal range is either equal or larger than 1.8 log CS. Fifth important testing or assessments in neuro-optometry is the vestibulo-ocular reflex testing. It assesses coordination between the eye movements and the head movements, which are crucial in balance disorders. Two famous and simple tests can be done in clinic to detect any VOR dysfunction. First is the head impulse test, which detects vestibular hypofunction. How do we do the head test? We're going to see a video right now. We rapidly turn the patient head while they fixate on a target, and we observe if there's a corrective saccade occurring. So if there is a positive corrective saccade, means the test is abnormal, and we likely have a peripheral vestibular dysfunction, and that requires a referral to an ENT as soon as possible. So we're gonna look at the video. You can see while the practitioner is moving from left to right, the corrective saccadic movements in the eyes. One more time. And that was very clear. Great. So we move to the next test, which is the dynamic visual acuity test. It's also an underrated test. It's really not used in optometry lately, but it can really rule out VOR dysfunction. So we let the patient sit and read the visual acuity chart as usual. And after noting the maximum VA that the patient could read, we let the patient reread the chart, but this time while moving the head of the patient at about 2 Hertz of frequency. And if we notice a loss of lines in the visual acuity, that means we have a VOR dysfunction, and that also requires a referral to a ENT doctor. We can have a look at the test done here. So the patient here is actually reading the letters normally, and then we will have a look on how the optometrist is moving the head of the patient while the patient continue reading the letters on the screen. We can do the test either patient seated or standing. Moving on to the sixth key assessment in neuro-optometry, which is the oculomotor function testing. This type of testing evaluates smooth pursuits, saccades, and vergence to detect eye movement disorders. The first test used in oculomotor function is the saccades testing. It measures rapid eye movements between two fixed points. So we instruct the patient to quickly switch fixation between two targets placed 30 centimeters apart. We're going to have a look at the video here on how we can do the saccades testing. You can notice between the two pens, there's a distance of 30 centimeters, and we ask the patient to quickly move the eyes between the two targets. And here we can document an accurate with saccadic movement with normal latency, no overshooting, and no undershooting. The next test is the smooth pursuit testing. It assesses the ability to track a moving object. It is a very similar test to the usual ocular motility test we do in orthoptics assessment. And we just hold a small target 40 centimeters away, and we move it horizontally, vertically, and diagonally to test the smooth pursuits. We can have a look at the video. We just ask the patient to follow the target in front of them. As simple as that. So we just note if there's any restrictions and if all directions are tested. One of the interesting tests to also use in oculomotor function is the King-Devick test. The King-Devick test is a 2-minute rapid number naming assessment in which a patient quickly reads single-digit numbers, as you can see in the photos here, and this evaluates impairments of eye movements, attention, and language function. And this test is really, really interesting in concussion screening. The last test in oculomotor function is the DM test, which is the developmental eye movement test. And this test assesses fixational and saccadic activity in reading tasks. Moving to the next testing in neuro-optometry, which is the cranial nerve testing, also one of the most important. This evaluates the function of the cranial nerves controlling ocular movement. And we know the 3 cranial nerves controlling ocular movements are cranial nerve 3, 4, and 6. The test we use are the H test, which is the 6 cardinal gaze movements test. It checks for eye movements restrictions. We do the cover-uncover test to assess ocular misalignments. And then we use any test for diplopia, especially the red lens test. A very beautiful illustration. We have here the 3rd nerve palsy, 4th nerve palsy, and the 6th nerve palsy. And we can check in each palsy the observation of each palsy. For example, in the 3rd nerve palsy, we can see in a forward position or a straight gaze that the right eye, if it's a right nerve palsy, that right eye turns upward and outward. And if the patient looks more to the right, there will be a smaller angle of horizontal squint. While if the patient is looking to the left, there will be no ability to adduct the right eye. Thus, we will have a larger angle of squint and a double vision further apart. It's very important to notice that in third nerve palsy, you can check here that we have also a ptosis. Since the third nerve palsy also innervates the levator palpebrae, we will notice ptosis in addition to the exotropia. Some types of third nerve palsy will have also pupil involvement, which means we will have a dilated pupil in addition to the ptosis and to the exotropia. A fourth nerve palsy will have the right eye turns upward and outward. There will be no squint to the same side of the palsy, but a more elevation to the opposite side of the palsy. The sixth nerve palsy will typically present with an esotropia, and there will be inability to abduct the same side of the nerve palsy with double vision further apart, and there will be no obvious squint looking to the left. Pupils testing are really important in detecting neurological cases. They assess autonomic nervous system function. So one way to test the pupils is the consensual light response test. So we shine a light into each eye and we observe direct consensual responses. We can see here in the video, when we shine a light on the right eye, we can see the right eye constricting, but also the left eye constricting. And now when we move to the left eye constricting. And if we look at the right eye, it is also constricting. The next test is actually the swinging flashlight test. It's one of the most famous tests for pupils testing. And this is where we rule out any RAPD or Marcus gun pupil. So we shine a light into each eye and then we compare afferent pupillary responses. We're going to watch this video. So we can see now we're shining a light on the left eye, it's constricting, then on the right eye, it's dilating. Left eye constricting, right eye dilating. This is a positive relative afferent pupillary defect in the right eye. Again, this dilates, this constricts. This is the swinging flashlight test. So how to quantify an RAPD? We usually use neutral density filters to grade the severity of RAPD. So the neutral density filters are actually similar to a prism bar. We place them in front of the normal eye to make the light less. And then we repeat the swinging flashlight test between the two eyes until we reach a neutralization between the two eyes. So, and then we note the neutral density filter that made that neutralization. And we could have a mild RAPD, which is up to a 0.3 log unit, until a 1.2 log unit, which is a very severe RAPD. Another fancy way of testing the pupils is actually the pupillometry. So in a hospital setting, you may find a corneal tomographer, which has the option of pupillometry. So this is a pupillometry analysis retrieved from MS-39, which is a corneal tomographer. And the good thing about a pupillometer is it tests the pupil in three light conditions: the scotopic condition, the mesopic condition, and the photopic condition. And not only it compares each light condition, but it also compares the right eye to the left eye, which is really important in this case. And newly, we are having handheld devices. So one of the new handheld devices is the pupillometer, the handheld pupillometer in the photo here by Neuro-Optics. Handheld pupillometers are really important, especially in neurological patients who cannot move, who are on the wheelchair. So handheld devices are really important. The most important testing for neuro-optometry is always the optic disc. So the optic disc examination will detect signs of optic neuropathies, papillodemas, and glaucomatous damages. So how do we usually see the optic disc? Simply with a direct or indirect ophthalmoscopy, with a fundus photography, or the way I like, with a slit lamp and a 90D lens. To further investigate optic disc anomalies, we use an OCT, and the OCT will measure the RNFL thickness and will monitor any thinning in the RNFL layer that could be attributed to glaucoma or multiple sclerosis or any other neurological cases. 4 important things to look into when we're examining the optic disc. First is the shape and the size. We can see here in the first photo a normal shape and size of an optic disc. In the second photo, you can see a hypoplastic optic disc. It's a very small disc, and we're always confused with the double ring appearance. The third and the fourth images show tilted optic discs. So the third image will show a horizontally tilted disc. The fourth will show a vertically tilted disc. And this is usually a congenital anomaly. And usually patients with tilted discs have normal vision, but it's important always to note the shape and the size. Second important thing in this examination is the color. So a normal optic disc will always show that pinky color, as you can see in the first photo. In the second photo, you can still see the pinky color, and then you look at the temporal side and you see some pallor, but that's not really pallor. That's the temporal side of the optic disc, which is kind of always less pinky than the nasal side. In the third photo, you can see a diffuse pallor. It's just a white reflection of the optic nerve. There is no pinky reflex, and this is an atrophic optic disc. In the last photo, you can see an optic disc with a sectoral pallor. You can see the pallor between approximately 9 and 11 o'clock, with the rest of the optic disc having normal pinky reflection. Contour is the third thing to look into an optic disc examination. So in the first picture, you can see a normal optic disc contour, normal margins, normal cup. And then we go to the second photo where we see a glaucomatous optic disc. And you can see a very large cup with the blood vessels coming out of the optic disc from the inferior part of the optic rim. And this is seen in very advanced glaucoma cases. We move to the third image where we see disc drusens, and you can clearly see there is no discrete margins and rim for the optic disc. And this is due to the accumulation of drusens on the optic disc margin. In the fourth photo, we can also see that there is no clear margin of the optic disc. There is a swelling of the optic disc, and you can see concentric lines between 8 and 11 o'clock. And those lines are called Patton's lines, and they are typically seen in optic disc swelling. Blood vessels are also important to test and to notice during optic disc examination. And you can see in the first photo, normal appearance. Arteries will always show rather smaller than the veins. In the second photo, you can see some tortuous blood vessels coming out of the optic nerve. And in the third picture, we can see another optic disc swelling with too many blood vessels. And you can see on between 1 and 4 p.m. again the Patton's lines, which confirms the optic disc swelling. So we hear a lot about the cup and the cup to disc ratio. So the yellow lines will show the distance of the cup, and then the black lines will show the distance of the whole disc. And this is how we calculate actually the cup to disc ratio. So we divide the distance between the yellow lines by the distance between the black lines, and this is how we get an optic to disc ratio. If we have a cupping of 0.5, that doesn't mean that the disc is actually ill, but we can have a normal cupping of 0.0, 0.1, even 0.5. You can see the disc in 0.5 has a normal central cupping. It's very important to always look at the symmetry of the cup. It should always be central, horizontally and vertically, and with normal appearance of color, normal blood vessels. With further investigation, we can rule out any glaucoma in this case, even in the 0.3, the 0.1, and you can see in the first photo, there's actually no cup seen. This is actually a case of a 62-year-old male who presented with blurry vision in the right eye. And upon testing, we find the optic disc of the right eye having a large cup and the left eye also having a large cup. But what really differentiates both cups is actually the color. So you can have a look here and see that the right optic disc has pallor, significant pallor, not only a large cup, but the left optic disc has a normal pinky appearance with no pallor. This is not the case of glaucoma, because that was first mistakenly diagnosed with glaucoma. But since the patient has equal cup in both optic discs, and only one optic disc or optic nerve has atrophy, the patient was referred to neurology, and it was a case of tumor compression to the right side, and that's why he had one optic disc with atrophy only and not both optic discs. So it's really, really important to rule out cases and not always rely on the cupping of the optic disc. The secret weapon of neuro-optometry is actually the color vision testing. The color vision testing is really important because it detects subtle neurological dysfunctions that affect the optic nerve and the visual processing. It identifies early signs of optic neuropathies, such as multiple sclerosis, glaucoma, and toxic neuropathies. It tracks progression or improvement in optic nerve conditions, and it is used in post-traumatic brain injury assessments to evaluate color processing changes. The famous tests used in color vision are the following. We have Ishihara plates. They screen for red-green deficiencies commonly seen in optic neuritis, but a more sensitive test and a more preferable test in neuro-optometry is the Hardy-Rand-Rittler test, because it detects not only the red-green deficiencies, but also the blue-yellow deficiencies with severity grading. D15 Farnsworth test is a really important test. The last time I saw this test was at university, honestly, but it's important because it assesses acquired color vision defects with association to neurological diseases. And finally, the anomaloscope, which differentiates between the congenital and the acquired color deficiencies. Where is the future of neuro-optometry heading? Where is the research of neuro-optometry heading? So we have the famous neuro-optometric rehabilitation therapy, NORT, currently applied in the US. It's really important. It has a lot of exercises. It has a lot of ways of treating patients with neurological cases, especially patients with TBI or traumatic brain injuries. And currently we are seeing a lot of virtual reality and artificial intelligence integrated in vision therapy and neuro-optometry, which is really promising. And there is currently a lot of advances and research in neuroplasticity and visual rehabilitation. Those are my contacts. I'm happy to receive your messages in case you have any questions. And currently, please place your messages and questions in the text box, and I'm ready to answer all your questions. Thank you so much.
Thank you, Mr. Charbel, for sharing with us your valuable insights. Really much appreciated. Before we end, I would like to ask you the questions that are dropped down on the chat box. So the first question is, what's the difference between the neuro-optometric rehabilitation and the vision therapy?
Good. So actually, vision therapy and neuro-optometric rehabilitation are really similar, and sometimes they complete each other. Vision therapy actually focuses on purely visual functions. And it usually focuses on amblyopia and on convergence insufficiencies and ways to improve them. While neuro-optometry rehabilitation focuses more on real neurological cases, including post-traumatic brain injuries, including multiple sclerosis, including strokes, because those patients require extra efforts. So their rehabilitation is actually more difficult than a normal patient with just a minor convergence insufficiency or amblyopia.
Okay, thank you. So the second question is, which visual problems can a neuro-optometrist treat?
Perfect. So since a neuro-optometrist is an optometrist, so there is plenty of problems we can actually treat. And mainly we can treat all the problems related to oculomotor functions. Means we can treat convergence problems, we can treat diplopia problems. And those two are really common in all neurological cases discussed. Prism prescription is quite interesting because it really resolves a lot of problems. We even prescribe prisms for visual field defects, and that requires a whole presentation, but mainly diplopia and convergence insufficiencies and visual field defects can be easily treated by a neuro-optometrist.
Okay, thank you. So also we have a question. The third question is, do visual problems manifest right after a brain injury?
Most of the vision problems will manifest right after brain injury because it's actually related to the traumatic injury to the brain. So some patients will manifest direct vision problems after brain injuries. That includes strokes, that include traumatic brain injuries, and that this is where the neurorehabilitation is important, because the treating those patients and improving their symptoms will actually take time.
Okay, so we have the last question is a neuro-optometric rehabilitation covered by insurance?
Well, actually, that depends on the regions and countries. I guess in Western countries like the US, yes, neuro-optometry is covered, but unfortunately, it is still underrated in, let's say, the Middle East area. We don't have neuro-optometry coverage by insurance here, and this should be actually checked by each optometry body in each country, and because regulations in each region and each country actually differ, they're not the same.
Okay. Thanks, Mr. Charbel Faraj, for sharing your deep expertise and practical insights on integrating neuro-optometry into clinical practice. Your presentation has truly enhanced our understanding and provided actionable takeaways for our everyday work. We also extend our senior appreciation to the VCA and the Eastern Mediterranean Council of Optometry for organizing this event, and of course for all our attendees for your active participation and engagement that makes these webinars meaningful and successful. Before we conclude conclude, I would like to say all the participants will receive a certificate for this webinar and for the last 3 And because of the World Optometry Day, which happens on March 23rd, there will be a lecture in collaboration with an international NGOs and international societies. So keep your eyes watch on the VCA pages for a further notice. And also, please remember that the recorded session will be available on the VCA YouTube channel. So feel free to share it with anyone who missed today's live event. We look forward to welcoming you at our upcoming sessions as we continue to learn and grow together. Thank you once again and have a wonderful evening.